Here we can see the relation between the semitendinosus and semimembranosus. And in muscles, this tendon goes to look for the pes anserinus insertion. Remember that this pes anserinus, as we will see after, is formed by the sartorius, the gracilis, and semitendinosus muscles. And here it has a very close relation with the saphenous major vein that grows in this insertion of the semitendinosus, and the saphenous nerve that comes from the femoral nerves, and also grows this pes anserinus and has a special relation with this tendon of the semitendinosus. In this picture, we can see the sartorius. Its muscular fibers arise just until the pes anserinus, the gracilis in the middle position, and the semitendinosus in the most posterior position. Also, we can see here the relation, and we can see here how this tendon inserts in the pes anserinus, but in the periosteum of the tibia, but also gives some expansion to the fascia that covers all the leg muscles. We can see here a transversal cut of this tendon, of this pes anserinus. We have in the most posterior part the semitendinosus in relation with the semimembranosus, the gracilis and sartorius. And this is exactly ultrasound vision of this cut, the sartorius in the more anterior part, the gracilis in this area, the semimembranosus, and the semitendinosus tendon inserted or to look for the pes anserinus. About the semimembranosus muscle, remember that muscular fibers begins just in the middle of the thigh and arise very inferiorly, and it follows by a strong ligament, a strong tendon that goes to look for also the medial part of the femoral condyle. Here we can see the semimembranosus and how it follows by the tendon, and it is under the semitendinosus muscles. We can see here also this semimembranosus tendon. We have to remove the pes anserinus in order to see can see it. And here we can see this tendon that goes to the medial part of the tibia. We want to finish it. We want to show how this semimembranosus muscle divides in 3 tendons. One of them goes to the posterior area of the popliteal fossa and to reinforce all the joint of the knee, posterior joint of the knee. And the other one was under the collateral medial ligament. We can see here this collateral ligament and how this collateral medial ligament is covered by this pes anserinus that cover all the ligament and also cover how the semimembranous goes to the insertion. In this picture, we can see the 2 more anterior expansion or division of this tendon of the semimembranosus, and here we can see when we remove the collateral medial ligament how the semimembranous tendon has 1 transversal fiber that goes just in this position. This will be this one, and 1 longitudinal fiber that goes to the more inferior part of the tibia, and always covered by this ligament, the collateral medial lateral. In these cuts, we can see the sartorius, the gracilis, and the semitendinosus. And here we can see the semimembranosus. This will be the condyle with the capsula of the joint. In this picture, we can see the sartorius, gracilis, semitendinosus that form the pes anserinus. And here we can see the semimembranosus and the division of this tendon in the more posterior part to reinforce the posterior joint, the posterior face of the joint, and the more anterior fibers that comes to look for the ligament under this collateral medial ligament. Also, it's possible to see in the medial area the fibers of the pes anserinus, sartorius, gracilis, semitendinosus, and semimembranosus, how it divides and goes under this collateral medial ligament. It's possible to see very clear how it goes under this collateral ligament. Well, to finish, only take home several concepts. The biceps femoris has a very close relation in the upper part with the semimembranosus, and also with the semitendinosus, and with the sciatic nerve, because always cover and protect it. The semitendinosus, it has a poneurotic structure in the muscle, very characteristic and very easily to see it. It has a very close relation also with the semimembranosus. The semitendinosus, it's always above the semimembranosus muscles, and it inserts in the pes anserinus. And about the semimembranosus, remember that goes to the lateral, to the medial position, that it has a very long poneurotic origin, and it has a very close relation with the semitendinosus, and insert one of the expansion of the tendon insertion goes to look for the collateral ligament, medial collateral ligament. Well, thank you for the attention, and I hope that you understand.
Thank you very much, Dr. Miguel. Our next guest speaker is Dr. Joan Carles Vilanova from Girona in Spain. His topic is weight-bearing MRI in sports medicine, a new technique for a better diagnostic approach.
Okay, thank you, Mario, for this invitation. Buenas tardes, good afternoon, everyone. I have nothing to disclose, and the outline of this lecture, after a brief introduction, I will go through the technique of a weight-bearer MRI, and we'll see several applications on the spine, the knee, and the ankle. We know how MRI is a technique of choice, as this is a unique technique that it combines the analysis of the bone and the soft tissue. We know how available is the technique, and also the improvement and continuous developments of this technique. The question is, there is a need, why we should realize to perform a weight-bearing MRI? Well, once we perform the standard MRI examination of the lumbar spine of this patient, once we then sit in the reading room to analyze this imaging, strictly speaking, this is not how we should read this MRI. Because strictly speaking, this is how we should read this examination. The patient was in this strictly position. It would change if I perform strictly a standing MRI of the lumbar spine with this patient. And then I will get the correct examination or in the strict position that the patient has been performed. So we can see that it's completely different analysis of the morphology of these examinations once it's performed in the supine position or in a loading position. We know that certain clinical symptomatology might be present only in certain stress maneuvers, either a sitting, either a standing, or either loading or performing several movements. So it is important that we might compare, and things will be different according to how I perform the examination. So the best proper way to perform the examination is to examine the patient in the moment that the patient has the symptomatology. That means perform a physiologic examination. Because certain features might not be present in a static position. It might be a pitfall, or we might overlook certain morphologic findings in a non-weight-bearing position. We know that in a loaded position, there is a complex forces on the joints, including active muscular, dynamic, gravity, inertial. So as we have seen in this example, either we analyze in this direction the image, but the proper analysis whether it's completely changed morphology of this example. So, as Dr. Faletti has said this morning, we are clinical radiologists. So our aim is not to report on imaging. Our aim is to report on patients. And we have, behind an image, there is a patient. So we have to correlate the symptomatology with the imaging. So this is our main purpose as a radiologist. And certain features might not be present whether we analyze an examination on a static position. So these morphologic changes that we might apply using a loading examination either might change the diagnosis, but more important, it might change the therapy because there is a different imaging period. So the technique that we can apply using a weight-bearing MRI examination, the power is because also we can compare. We can perform a supine examination and then an upright examination. We can perform different dynamic maneuvers. We can quantify these morphologic changes. Important to correlate the imaging with the symptomatology of the patient. We can induce the symptoms performing stress maneuvers. And from different literature reports, it has been shown a range variation of the pathology using an upright MRI from 15 to 25. Our technique is an open MRI, ESAOTE, using the standard protocols. And we first start with an upright position, and then we perform the second examination on the supine, and it can be performed with dynamic maneuvers and either standing or in the supine, and for the cervical spine in the sitting position. We'll see different applications in the spine, in the knee, and in the ankle. This was our first results on the analysis on the first year where we performed this analysis. We saw several changes concerning the disc, 4% of normal disc on the loading position change at L3, L4, and L4, L5, 9% from a normal disc to a protrusion at L5, S1. The neuroforamen decreased in 6% in L5, S1, but the most significant change was on the spinal canal size. We evaluated the area, and also we evaluated the sagittal diameters. The significant changes were in these strictly levels, L3, L4, L4, L5, not at L5, S1, with different significant numbers in this context. This is the example we saw at the beginning. The important change as it can be realized especially in the axial view, complete stenosis that it is not depicted in this supine position examination. Other applications on the spine. Here you can see this former motorcycle rider from the Dakar race. There is a slight increase in this protrusion in the cervical spine. Instability, not only indirect signs, but direct signs that we should realize, and several reports have seen a mean average change of the alignment, as it has been reported, of about 55%. Here we can see this example, 39-year-old plays tennis with symptomatology while playing, and after the loaded examination, we can see complete change of this alignment, and we can see the decrease of the size, and especially the significant subluxation in this particular case. As we have seen in our experience, the change from a normal disc to protrusions, herniations, higher extensions, it has been shown from the literature, I mean 9% presence of herniation with a loaded examination with a range between 4 and 20. And here we have a specific example that this protrusion that we see in the unloaded position, but we can see the increasing protrusions in the upper levels that it's not seen in the supine position.